Hello, students. It's time to begin work on intracranial regulation. I've got a PowerPoint on brain death and organ donation. This semester, we talk about organ donation from the point of view of the patient who's been declared legally dead, and they will be donating organs. Next semester, we talk about organ donation from the perspective of a patient who's a recipient of an organ. So this is the first in a two-part piece to this concept in this exemplar. But I'm going to share my screen and we'll move into the PowerPoint. Okay, intracranial regulation, the concept of brain death and organ donation. There's actually two kinds of death that donate organs, and so we'll talk a little bit about both, but brain death is included here, and that's why this is in the exemplar. So there are basically two federal laws that have come about in the last 20 years or so, and both of them address the requirement of hospitals to provide education and an obligation to allow organ donation as an option to families when there's a person that comes in that's a viable donor. If we're not compliant with that, there's actually penalties that are pretty harsh. But every time somebody comes to the hospital now, they're offered the opportunity to sign organ donor cards or organ donor releases, and they're given that information. We do things a little differently in the United States than the rest of the world does. In the United States, you have to opt in to be an organ donor. My slide isn't doing what I want it to. I'm trying to get it to go from the beginning, and it's not going to whole screen. Okay, so in the United States, we do it a little differently. In the United States, we opt in to be an organ donor, and you have to sign a thing that says, yes, I want to donate organs, and these are the organs I'd like to donate. In many parts of the world, you have to opt out. Everybody is a viable organ donor unless you sign a document saying you don't want to donate. So it just is handled differently in different places. But in the United States, everybody's required to opt in. Now when you sign up for a driver's license and you go in to register as a driver or to renew your license, you have the opportunity to fill out the organ donation piece on the back of your driver's license. In addition, many, many people have signed formal documentation. They have it on file with their lawyers and they keep it with them. So if they have to be admitted to the hospital, they already know what their wishes are and it's made clear to the families. So how much of a need is there? Well, at any time in the United States, there's approximately 100,000 people on the waiting list to receive organs. We do about 28,000 transplants a year. Any body part pretty much can be donated. We really have come a long way with this. There are organs that can be donated and used, and there are tissues. Organs that can be donated, a heart, a lung. We have lobes of our lungs, and any one lobe or any half of like the right lung or the left lung or any lobe of the lung can be used to donate. The liver, and the liver has lobes, so it can be divided into multiple parts for donation. We have 2 kidneys that can be donated. The intestine can be used for donation, all or part, and the pancreas. And we can use the head of the pancreas, the tail of the pancreas, the entire pancreas. Depends on why people need it. Remember, different parts of the pancreas have different function. Then also there's tissues that are used. The tissues involve corneas, veins, arteries, valves of your heart, bone, connective tissue, skin, and stem cells are considered a tissue. You know, that's bone marrow harvesting or peripheral stem cell harvesting. Talked about that briefly with the hematopoietic cancers and in the cancer unit. Every time somebody gives an organ or a tissue, their cells have antigens on them. And the recipient has antibodies that are going to fight foreign antigens. So every person that is going to be an organ donor must have their tissue cell typed. And so we do an HLA testing on it. And that human lymphocytic antigen, that is the antigen that most of the time the white cells would fight on a foreign protein. So that's the compatibility testing. Yes, we're going to test blood type, but we're also going to test lymphocytic antigens to make sure that the donor organ is compatible for what the recipient needs. The donor, we have to identify them as early as possible. We want to know if somebody's a viable donor at the beginning of their healthcare journey. The longer somebody dwindles in the healthcare system, the more opportunity for nosocomial infection, the more opportunity for other problems to arrive, poor perfusion of organs, poor oxygenation of tissues that would make their organs non-viable for transplant. So the idea is that we know right up front if somebody's an organ donor. It's not that we treat somebody differently if they're going to donate organs. Many patients fear that if they sign the organ donor card, when they come in, if they are critically ill, we'll say, there's no reason to treat them as much. They're going to give their kidneys to somebody else, and that we would let them die. That is not the case. That is not how this works. We don't do that. We treat everybody with the idea that they are going to survive, and to the extent that their advance directives and their power of attorneys for healthcare tell us to direct their care. But once somebody's deemed that they're probably not going to live, whether it's brain death or circulatory death, and we've identified them as a donor, we need to set that apart and start being aware that even though we may still be trying to save them, we have other things that we have to do if we're going to make their tissues viable. We want to make sure that if somebody's dead or near death, or we were about to declare them dead, that we notified the organ procurement center. The organ bank is going to send somebody to the facility to talk to the family and to help understand the whole process. There's actually organ donor designation lists that people are on. We want to make sure that person has an advance directive that allows us to harvest organs, or that the family has given permission. So the family will make the decision if the patient has not already designated in their own documentation. And like I said, there's two different kinds of death that we deal with. There's brain death, where somebody is no EKG, no EEG, no brain perfusion. We're going to talk about that in other places in the intracranial regulation unit. So this would be somebody, the family is usually prepared. It's like we think they're brain dead, and then we test, and then we come back and we test again later. And we find out, yes, they are brain dead. They're already on life support, and we harvest the organs, but they've been declared dead because they have no brain function. Circulatory death is a little different. This is the heart and the lungs are on life support, and we're using drips and everything else to keep them alive. And there's no opportunity for this person to live if we remove the ventilatory or perfusion support, whether it's a LVAD or whether it's ECMO or whether it's a ventilator or whatever. If we remove it, that patient would surely die. And so the family says, well, I would withdraw the life support, but I want to give organs. So we can't just withdraw the life support and wait 3 or 4 hours and take organs. There's a whole process we have to go through if organs are going to be donated in that circumstance. So the brain DBD stands for donor by brain death, or donor by circulatory death, DBD or DCD. If you're a patient who's been declared a donor because of brain death, you can actually give up to 8 different organs: your liver, your pancreas, your heart, your intestines, your kidneys, and then multiple tissues, lots and lots of tissues, skin and corneas and all kinds of things. But if you're a cardiac death, a circulatory death, then only the liver and the kidneys are actually given. The lungs and the heart are declared non-viable. Sometimes we can still remove skin, sometimes we can still remove other tissues like corneas, but as far as organs go, only livers and kidneys are going to be able to be taken. The tissues, again, multiple tissues can be taken from either kind of patient, and so lots of viable tissues can go to lots of different patients. So how do we determine if somebody's truly brain dead? Well, they won't respond to commands. They have flaccid paralysis. Their pupils are unreactive and fixed. They have no oculocephalic reflex no corneal reflex. If we inject water into their ear, they get no nystagmus. And if we rub the cornea with a little piece of cotton, there's no blink reflex, no corneal reflex. They don't respond to supraorbital stimulation. If we push on their eyes, above their eyes, they'd have no response to that. There's no, the ocular vestibular reflex, I said if we put water in their ears, we already talked about. Ocular cephalic reflex, that's doll's eyes. If we move their head, there's no lag in the ocular. Like we move the head with doll's eyes, you either have a fixed gaze, so when I turn the head, the eyes don't move, or with most people, if I turn my head quickly, my eyes lag behind the head turn. That's the oculocephalic reflex. And a healthy brain will lag. If you have a fixed stare when we turn the head, that's no oculocephalic reflex. No gag reflex, and no spontaneous respirations. They would have to be 100% ventilated, no respirations on their own. They can still have their own heartbeat because the brain does not control your heart. Remember, the heart has automaticity, and the sinus node can stimulate an independent heartbeat, even in the absence of cerebral innervation. So then once we have all these reflexes in place, we say, they're not doing anything. They're not responding to pain. They're not responding to reflexes. They have no stimulation makes them blink or move or whatever. Then we'll do an EEG, which measures the electroencephalography. That's the electrical brain waves. A brain dead patient will have no EEG activity at any level of the electroencephalogram. There's different kinds of waves. They'll have none. Then we also can do a brain scan, and we can measure the brain blood flow into the brain. And if there's no blood flow to the brain, that is a automatic definition. It means automatically meets the definition of death. So a negative cerebral blood flow to the brain, evidence of brain death immediately. And with an EEG, they'll do 2 of them a few hours apart to make sure, and then declare it as a brain death. The coronary death the circulatory death is a little different. The patient is going to be in the ICU or under care. They're going to be prepped and draped, and we're going to have them ready. We want their face and their hand exposed. They'll be on life support, and the family will come in. They'll say goodbye. They'll touch them. We'll go through that process. We want to care for this patient the same way we care for any other patient. If the family thinks they're in pain, or they won't have pain if they're brain dead, but with circulatory death, you can still have pain. Their brain is still functional. So we would treat them for pain. We'll heparinize them. Well, their drips will continue. We're going to do everything we can to keep perfusion up, keep oxygenation up, to optimize that, to keep the tissues viable. Let the family say goodbye, and then they'll be taken to the OR, and we'll withdraw life support. And if death does not occur, usually we wait 5 minutes, and death should occur. Like if we withdraw life support, they're not going to breathe, and their heart should thereafter stop within just a few minutes. So at 5 minutes, we'll begin the procurement. If the patient doesn't actually die within 60 minutes, like I said, their heart doesn't stop, or if their labored respirations agonal respirations don't completely cease, we'll put them back, we'll take them back up to the critical care and we abandon this process, and we can't harvest organs. So because it's been too long with them being hypoxic and poor perfusion, and the viability of those organs dramatically decreases. So usually while we're downstairs going through this process, the hospital chaplain is staying with the family and talking them through, keeping them updated, letting them know what's going on. Usually there's a procurement center representative there as well. Okay, then for a living donor, some tissues can be given a living and some organs can. You cannot give a heart if you're a living donor. I can't give my heart to somebody, but I can give a lobe of my lungs. I can give one of my 2 kidneys. I can give skin. I can give tissues, bone. I can give collagen tissue. I can give blood, stem cells. Those are tissues that we donate. Sometimes you can direct that organ donation, say, hey, I know my stem cells are the same type as this child who's got acute leukemia. I want to direct my donation, or we can do a non-directed, and they can freeze or store the organs and tissues until they can find an HLA compatible donor who uses them. You have to be fit and in good overall health to donate organs. You can't have underlying cancer, diseases. There's no chronic illness, especially in the organs that we're about to give. We have to have consent, and we get good lab testing. It's a long process, and the person can change their mind at any time. This process of identifying, testing, qualifying, they can change their mind at any time. There are risks to the living donor. They're going to have a surgical site that could get infected. If they give a kidney or part of the liver, they still could have their own organ fail later. Like if you give one kidney, the other, and go into kidney failure later, or if you give a lobe of your liver and then you go into liver failure, you'll have less viable tissue to process. So they can have other complications. They'll have scars, there may be pain. So we have to give them due counseling and make sure they know what they're getting into and that there might be long-term ramifications. So, they basically could be putting themselves in health jeopardy. So we have to make sure good teaching is done. There's always an ethical dilemma with organ donation. There's scarce. We talked about how 114,000 people need organs, but we usually only have about 28,000 organ donation surgeries in a year. So there's a scarcity of resources. There's not enough kidneys, hearts, pancreases, and livers to go around. The lifestyle of the recipient might be something that gave them death or damage to that organ and could be controversial. We usually make sure that person is no longer using alcohol or drugs and that they're psychologically stable to receive the organs. But there's always questions that arise along the way, and there's ethical issues that may come up. What if you have two HLA compatible donors and one is a 65-year-old patient who is otherwise they need a heart, but the other one is a 8-year-old child that needs a heart? Who do we give priority to? Well, do you base it on age? Do you base it on lifestyle? What do you base it on? So the ethics of the issue can be reasonably complex for people that are involved in this world and caring for these patients. It also is very expensive. It costs the recipient of an organ quite a lot of money to receive that organ. Plus there's a lifetime of therapy and follow-up that's involved. The urgency and a need for that organ has a lot to do with who gets that organ. If one person is expected to die soon if they don't get an organ, another person has a longer life expectancy, it could move people up higher on the organ donor list. And the other part of it that's ethical is sometimes nurses and other healthcare providers are bothered by having to care for someone that's already deceased. If they're brain dead, sometimes nurses and other providers aren't comfortable caring for that body because they feel like that person's already dead. Why am I wasting my nursing resources, turning them, oxygenating them, giving them medications when we feel like that person is no longer alive? And some nurses have real ethical issues with that. If you're going to be a donor, we have to get consent. Lots of people sign up for it. But if I sign my organ donor card and then I get in a massive car accident and I have a brain injury, it doesn't look like I'm going to be viable, my husband or my children could overturn that decision. The family still has to pretty much agree with it because most places are not going to fight the family to get a kidney or a liver. We hope that all donors have informed their family of what their wishes are and they're in agreement. We know that when somebody comes in, we've identified the donor, either by driver's license or family expressed wishes or whatever, that then we get an organ procurement center representative there, and they will go through the whole process with the family and make sure everybody understands. After consent is achieved, we'll still do extensive testing. That patient, even though we've had them in the hospital, we're going to test them for HIV, hepatitis B and hepatitis C, tuberculosis, and a host of other communicable illnesses to make sure that we don't accidentally transmit something we were unaware of into a recipient. We want to make sure that the family has all their questions answered, that the patient is treated with respect, the family has time to say goodbye, everybody gets adequate time to grieve, and again, making sure that full details are provided. So what do we have to do to make sure organs stay viable after death is declared? Well, we must make sure that the patient's airway remains patent. So usually they're ventilated. We also have to make sure their body temperature doesn't get too high or too low. We want to make sure their fluid status remains stable. So we're going to keep giving them adequate fluids. We want to make sure they don't get the opportunity for an infection. If somebody's got a catheter and a ventilator, the risk for ventilator-acquired pneumonia or a CODI or a central line infection, if they have a central line, are still very high. So we're going to maintain great asepsis and try and prevent all forms of infection and prevent any other complications from coming to these organs as that person is laying in the hospital bed for several hours being cared for after death. So our general rule of 100s, we want to keep that PaO2 up as high as we can, preferably at 100%. Keep their urine output going at over 100 mils an hour. That may involve giving diuretics. That may involve lots of hydration, but we don't want it to go over 200 mils an hour. If the person is brain dead, there is always the risk that along the way to that process, they develop diabetes insipidus, which is a lack of antidiuretic hormone where they would have excessive urine output, and then their kidneys are not viable at that point. We have to make sure they don't have diabetes insipidus at the point of donation. We want to keep their systolic blood pressure over 110 and their body temperature at about 100 degrees. That would be Fahrenheit. So over 97 and less than 102. Usually 100, 101 is about as high as we want it to go. So we also want to make sure that if they have to be treated with vasopressin to avoid the diabetes insipidus, we will. Vasopressin, again, that's in IV ADH. We want to make sure we can give dopamine, we can give norepinephrine, we might have to give hydralazine or other vasodilators depending on what this body is doing in a state where they're no longer viable. Their brain cannot manage the turning on and off of various sympathetic and parasympathetic outflow because their brain is non-functional. We'll give them volume expanders like hexastarch or albumin. We can give them blood if they need it to maintain hydration and perfusion and adequate oxygenation. And don't worry about the intracranial pressure. We don't donate brains, so excess intracranial pressure, which we're going to talk about later in this unit, is not an issue. Normally when somebody's got an intracranial problem, we do worry a lot about intracranial pressures. But if somebody's already been declared dead, the intracranial pressure is not an issue. We are not at the point in this country where we're donating brains as an organ that we harvest. Quite often the patient will have to be on a cooling blanket or a heating blanket. We usually a cooling blanket because we want to decrease the oxygen demand, but we don't want to cause ischemia to organs. So it's a balancing act, and it will be up to the provider and the nurse who's monitoring that patient and watching organ function. So one person who's been declared brain dead and they can give a maximum of tissues, they can actually up to 75 different people could receive their tissues because you have corneas from 2 eyes, you've got lots of skin sites to donate and bone sites, lots of pieces of intestine, you have veins or arteries, you have mostly veins, you have the 2 kidneys, you have multiple lobes, you have 5 lobes of your lungs, you got several lobes in your liver, so it can be split up and up to 75 people can be helped through that process. So giving organs is giving a gift of life to somebody who would not be able to live at the time when your loved one or you are dying, so that you can sign up to be an organ donor. And I encourage everybody to consider that option. So that's the end of this presentation.